privilege and delight to welcome Dr. Brett Dyer for our presentation today. Brett, in fact, Brett has actually has been a mentor to me. He was one of the very first individuals to really take periodontics at the level it is and put it into the water lace cascade. He is Texas. Sugarland is his practice. He's been in practice there, an excellent practice south of Houston. He is training Baylor, University of Texas at Houston in periodontics. But for the most part, and he continues to still do some excellent training courses with Bill Chin in periodontics, but he also was probably part of the genesis of what we consider to be the Repair Perio program. So it's truly an honor to have Brett speak to us tonight on an area that we have been discussing at quite a length, and that is this area of putting water lace or lasers into aesthetic dentistry. So welcome, Brett.
Thank you very much. It's a pleasure and honor to be here tonight. So tonight we're going to talk about aesthetic crown lengthening, or my portion of this is aesthetic crown lengthening. And I find it's something that you apply more and more to the procedures that you're doing. Whether you're doing implants, the quandary of anterior implants, making them symmetrical. It's so easy to do if you've got your laser. And then smile enhancement, just for after ortho or just in general. You'll find so many different applications for this type of procedure. It's one of the most common procedures that we use. I wrote a paper on this in the Journal of Cosmetic Dentistry and went through the steps. But tonight I'm going to show you what we're actually doing right now. So, but before I show you the steps, a few things that I'll share with you that I think about before we do a case. And so that first one, face height, is the mid face equal to the lower face. There are some times when this procedure is not, the one I'm going to show you tonight is not the right procedure. For example, say that there's the lower half of the face is really long. If you do crown lengthening, what you'll find is that you still have somewhat of a gummy smile with this technique. And maybe you have to do something called the lip lowering with it in addition. Or the opposite, say that the distance from the base of the nose to the top of the lip is really small. Those patients tend to have a hyperactive or very active upper lip. And so not only do you have to do a little crown lengthening, but frequently you have to use Botox in the upper lip to keep the mobility down. We all think about in terms of high smile line and low smile line when we're talking crowns, but really I think of the gingiva as kind of the framework for the teeth. And so when I'm looking at a patient's smile, I want to be able to see a slight pink framework around the teeth in a proper proportion. Other things to consider, though, this type of procedure I'm going to show you tonight is really based on crown lengthening or anteriorly shaping the facial tissue, facial gingiva. But if the teeth are really worn down, I've got a friend of mine who's ground his teeth down to little nubs all the way around. And when I did crown lengthening for him, I had to do something called functional crown lengthening. That's where we crown lengthen all the way around the teeth so that he could have restorations. And again, this procedure that I'm going to show you tonight wouldn't necessarily be the ideal procedure for that. And the first thing we have to ask ourselves when we're doing this is the gingiva coronal to the CEJ. If it is, then this is a potential procedure for what we could do. So this is an example of a severely worn dentition. Someone who's just been a grinder all their life. You can see their teeth look like they've been milled down. And so the type of crown lengthening for that is functional crown lengthening. It's circumferential. It's a different technique than what we're going to show you tonight. This patient right here. So another thing to always consider before you do this procedure that I'm going to show you tonight is how much gingiva does the patient have? Attached gingiva, keratinized gingiva. If I were to resect this young lady's gingiva right now, it would eliminate her gingiva and she'd have nothing but mucosa left. And so we want to leave at least a 3-millimeter band of keratinized tissue facial to the teeth. And so think about that. Measure where the CEJ is and where you're going to crown lengthen to, and decide, well, after I'm finished crown lengthening with this resective technique, will it leave 3 millimeters or more of keratinized gingiva facial to these teeth? And if not, then the proper technique, like in this case, was an apically positioned flap, but not the aesthetic procedure I'm going to show you tonight. So what we're basically talking about tonight is altered active or passive eruption. So as the teeth erupt into the mouth, and if the bone stays at the CEJ and the gingiva is coronal to the CEJ, that's called altered active eruption. If as the teeth erupt into the mouth, the bone actually recedes apical to the CEJs, a few millimeters, but the tissue stays on the crown of the tooth, that's called altered passive eruption. And the technique we're going to talk about tonight is good for both of these types of procedures. You'll find that a lot of orthodontic cases will benefit from this procedure. And this is just to give you an idea of the vast difference of crown lengthening on one side versus the other. If you'll, I bet you've got plenty of patients like this in your practice. They come in, they've been wearing their braces for a couple of years or whatever the case is on a young patient that hadn't been brushing well, and the gingival has gingival enlargement. The inflammation has caused the gingiva to grow, and then over time, it's become more keratinized. And look at the middle section. Man, what a vast difference. So this patient not only is going to have straight teeth now that the wires are coming off, but their teeth are going to look just incredibly different just from having this approach. It's really a life-changing effect for many patients. You'll find that a lot of patients come out of their cocoon, or it really opens up their personality to have a procedure like this. It affects their confidence greatly. And when I'm doing this, I like to think of, as I said earlier, I like to think of the gingiva as the frame for the teeth. And I like to see the gingiva fade into the corners of a patient's smile. So this is a good case of that. The first case, you can see she needs crown lengthening. Her CEJs are covered well with the gingiva. But not only that, how far do we want to take this contouring back, this aesthetic shaping? And for me, I like to take it back so that the teeth disappear into the corners of their smile. This is another type of case like we talked about in the beginning too. There's a long premaxilla. And if I just crown lengthen the teeth, well, she's still going to have a gummy smile. And so not only for this particular case, not only did we do a crown lengthening, but we did a lip lowering procedure as well. The alternative to the lip lowering procedure is orthognathic surgery. But in today's climate, the cost of doing orthognathic surgery is outrageous. You know, I mean, if they have 60 grand to go in and have that done, that's one thing, but you'll find that insurance doesn't cover it well. And so lip lowering procedures with crown lengthening are a great option. This was the patient, this is the daughter of a referral of mine. And we did both crown lengthening and lip lowering on this case. So for any of these cases, I recommend that you wear magnification. You need to have at least a 3x magnification as a minimum. Right now, when I do surgery, I use a 5x magnification. And the goal is you want to be able to take, like on the upper side of your screen, you can see me lifting up the tissue. I'm using like a little neighbor's probe. Just any type of curved probe or explorer will lift up the tissue. And if you're wearing enough magnification, you can see down the length of the root and you can see the crest of the bone. And that's how you are able to do this procedure with a minimally invasive approach. So yes, what we're talking about tonight is a closed crown lengthening approach, but in truth, it's really just a minimally invasive crown lengthening approach, meaning I'm not doing anything closed. I'm actually looking at it the entire time that I'm doing it. I'm just wearing really good magnification so that I can lift the tissue up and then recontour the bone underneath the gum as I'm looking at it. I'm just doing it through such a small flap that I don't have to suture it afterwards. So this is basically an envelope flap. Let me take you through this process. So to begin with, take your probe and measure underneath the gingiva and pass it past the CEJ, and then drag it back to the CEJ, and that's your number. And then you'll take your probe out of the pocket, put it on the outside of the gingiva, and poke a hole at that number that you just measured. So again, you measure past the CEJ, drag your explorer back to the CEJ because you more accurately measure it that way, and then make a bleeding point. So we're going to crown lengthen back to the CEJ in this particular case. And I would recommend you might make more than just one bleeding point per tooth. I know when I first started doing this, I would make 3 or 4. Make a lot because it's easy to follow the dots, right? You remember doing that when you were young in those coloring books. You could trace the dots. Well, you're going to do the same thing with your laser. Think of it as your little micro eraser. So we're going to recontour the tissue. We've made our bleeding points. And so I'm going to recontour the tissue back to those bleeding points. And I'm keeping the tip of the laser parallel to the crown so that I don't create notches or just cuts into the root surface. And I'm going to try to follow the CEJ. So you'll see me punch under the tissue every now and then to verify where the CEJ is. And as I'm contouring the tissue down, I'm going to actually touch the CEJ, verify where I am, and then keep contouring to it. As I get close to the CEJ, I'm going to start to bevel this tissue at like a 45-degree angle because butt joints don't look good. You really need a beveled joint when you get to the CEJ. It doesn't have shadows that way. It just looks nicer. So here you can see I'm recontouring the tissue and I'm constantly verifying where the CEJ is as I go. And as I get close, I bevel the tissue. And I will tell you that in almost all of the cases that we do crown lengthening on, I have to do a frenectomy. It's just part of the procedure. And so you'll see me remove the frenectomy to the height of the vestibule. And then after I've incised those fibers or vaporized those fibers, I'll angle my laser so that I create a bone scar. I'll go back and forth over the bone to prevent this frenum from bouncing back. And that's what I'm doing right now. I'm going back and forth, creating a nice bone scar so that later we won't see this frenum bounce back into our picture. I get several questions on when I'm doing the soft tissue recontouring, do I use a hard mode or a soft tissue mode? And I'll tell you there's benefits to both. When I'm doing this first procedure, as you've been seeing on the tooth number 9, I really like to use a soft tissue mode more than anything, with maybe just a little water, maybe keep it at 5% water or less, and maybe 40% air. And what you'll find is the tissue vaporizes or it ablates really smoothly. The hard tissue mode can be used to do this as well, but it's a little bloodier. And so for that reason alone, I tend to do this first step with the soft tissue mode. And here I'm still working on my bone scar and resecting the frenum. Generally, when I'm doing the frenectomy, I'll take the tissue as it edges towards the teeth. I'll still take it down some. So I'm not just trimming it back in the middle. I'm actually removing some of the thickness of those fibers. And here I go. We're starting off on the next teeth, and I'm just going to recontour the tissue again back to those bleeding points. And I extended this crown lengthening all the way back to the corner of her smile that you could see. So I'll actually have the patient on the initial appointment, I'll actually have them smile really big, and I'll let them hold a mirror. And I say, this is how far the crown lengthening is going to go back. And I'll verify that if I crown lengthen that molar, I don't crown lengthen past the CEJ. So if crown lengthening past the CEJ would make the tissue fade into the corners of her smile, I might have to compromise with that, because I don't want to crown lengthen beyond the CEJs. So you can see I've taken it both sides, and frequently what you'll find, or at least I find, is the transition between the first premolar and the canine. The bone between those two teeth is frequently bulbous. And so I'm going to show you somewhat of a combination procedure today of why you might have to lay a flap or a papilla flap in isolated spots of your crown lengthening. So the next step is we've resected the soft tissue. And the rule of thumb that I'm talking about right there is for every millimeter of soft tissue that you resect, you need to resect the same amount of bone. And so to begin with, I begin by troughing. I'll place the tip not in the full interproximal area, but in the thickness of the papilla. And then I'll start creating a slot in the soft tissue from the free gingival margin down to the bone. So I'm inside the sulcus now, and I'm just trying to loosen the tissue. So you see, I start at a thick part of the gingiva, and I make a little slot down to the bone, and then I start carrying that slot laterally from side to side. And I usually start in the thick part of the tissue, because what you don't want to accidentally do, the tissue gets thinner over the mid portion of the root. And what you don't want to accidentally do is start cutting notches through your tissue. You want everything to be smooth and clean. So I've already contoured it back to the CEJ. I don't want any notches that will extend it past that. So after I've loosened up the tissue, I've troughed, I'm going to take my a curette or neighbor's probe or some type of small instrument, and I'm going to lift the tissue up. And now with high magnification, as you're lifting it up, you can see the surface of the root and you can see the bone. So this isn't really a closed procedure, is it? It's just a micro procedure. It's a minimally invasive procedure. And so that's what I'm doing. I've lifted up the tissue and I'm recontouring the bone to follow the CEJ. And I'm going to resect the bone. If I resected the soft tissue by 2 millimeters, I'm going to resect the bone by 2 millimeters as well. If I resected the soft tissue by 3 millimeters, I'm going to resect the bone by 3 millimeters as well. And so here I'm lifting up where I've troughed the tissue, so the tissue's loose now, and I'm wearing my high magnification, and I can lift up the tissue and recontour the bone to follow the patient's CEJ. And we're not worrying about trying to bevel the bone or anything at this point. We're just making the resection smooth. So I'm trying to keep a smooth, even motion and just make sure that the bone is evenly resected the same amount that I resected the soft tissue. And as I was mentioning earlier, frequently the bone has, if when you're trying to retract the tissue, you can't see the bone, you can't see the full thickness of the bone, that's an indication that you need to lay a flap. And so in this case, I've actually laid a little papilla flap. I pulled the papilla back so I could see the full thickness of the bone, and I resected it. And now I don't want to, just like I didn't want to leave a butt joint in the soft tissue, I don't want to leave a butt joint in the bone either. And so I'm taking a rotary diamond just on a slow speed, and I'm contouring the bone to have a bevel, just like I did the soft tissue. This will prevent you from seeing dark lines in the tissue as it matures and in the future for this patient. Everything will just look smooth and pink. So I'm beveling the bone into the surface of the root. in that one spot where I laid a flap, I have to suture that back. But in the other areas, I just take a wet gauze and I'll hold pressure against it. But I'll tell you, before we do that step, after I've resected the bone, I'll bring my staff in and I'll have each one of them, one at a time, look at the area, and I'll say 8 and 9, are they symmetrical? 7 and 10, are they symmetrical? 6 and 11, are they symmetrical? And anywhere they can find the most nitpickiest thing, I'll go and make that change with the laser right there. And then after everything, I usually do that with 2 or 3 staff members, and then I usually do it with whoever brought the patient, and then I finally let the patient hold the mirror and look and do the same thing. 8 and 9, 7 and 10, 6 and 11. I want everyone to see that the symmetry is perfect. And after we've had that, we'll take rolled up wet gauze, hold pressure on the tissue until the blood clots underneath. You want a thin fibrin clot, and then we'll seal the gum to the teeth with a cyanoacrylate. Glue stitch is what you'll find it if you were to Google it. Google glue stitch, and that's the type of glue that we use to seal this to the teeth. So that's the process of aesthetic crown lengthening. I know we've covered it kind of quick, and if you have any questions, I'll be glad to answer them at the end. Thank you.
Thank you so much, Dr. Dyer. That fantastic step-by-step video you had there, and I'm sure we'll have some good questions here at the end. So again, to our audience, if anything is in your mind that you would like Dr. Dyer to answer, use that Q&A tool at the lower toolbar of your screen. And with that, let's pass it on to Dr. Lau to transition away from our crown lengthening topic, and we're going to spend a few minutes to focusing on gingival depigmentation. So Dr. Lau, it's all yours.
Well, thank you, Joe. We wanted to take a look at 2 areas here for this particular webinar. One was the aesthetic crown lengthening with either a mini flap or basically closed. And the second area that we wanted to discuss with you is actually an increasingly popular patient wanting something called gingival depigmentation or gum bleaching among the lay public. And so the thing that I enjoy about this process of gingival depigmentation is it's not only aesthetically patient pleasing, but it's also one of the areas that I continue to reinforce with us is something called value-added revenue. And value-added revenue implies that this is something that you weren't doing in your practice before. This does not substitute for a high-speed handpiece per se, but this is something that's unique that you're able to add to your practice and therefore not only enjoy your patients desiring it, but also having a different revenue source. So let's talk for a moment about this thing called pigmentation. You may be aware, especially if you go back to our dental school days, that when we call this hereditary pigmentation, the melanocytes, which are going to produce this melanin, they reside in the basement membrane, and the pigmentation is actually in a suprabasilar condition. And if you look at our clinical slide in A, and then you go down and look at our histological side in B, in order to remove this pigmentation, naturally you're going to have to remove the layer of the epithelial tissue, but then also you need to get into the basement membrane and to a certain degree, a portion of the connective tissue. Now you may be asking yourself, just how deep can I go? And I'm going to suggest some rules for you as we move forward to this, because if you're too shallow, I think you know what's going to happen. You're going to get repigmentation. If you're too deep, then you possibly will be in the osseous, and that is something that none of us would desire. When one looks at pigmentation, you may be aware that it is not just about this melanocyte component. Well, we have a very serious condition like melanoma or sarcoma, which we saw with HIV, vascular abnormality. Every now and then you've seen some colors in the gingiva that are not necessarily black, but more of a red color. Amalgam tattoo, heavy metal poisoning. By the way, we've seen this with hormonal imbalances from Addison's disease, so forth. There is a drug-related pigmentation, and I know all of you have seen pigmentation with individuals that are smokers. So if you and I, in our case selection, in our discriminating diagnosis, if we rule out all of these kinds of things, then we're basically ending up with hereditary pigmentation. Now, what did we do before? Well, I can suggest to you that you can find a significant number of references to doing depigmentation. This is not something new. That before and even now, we see folks, as you see in the upper right, using a blade. You possibly know that there are individuals that have used rotary diamonds. I would not use a carbide here, but if you look closely, one of the problems with the blade, I think you can imagine, would be hemorrhage. One of the problems with the diamond is that literally the gingiva is just almost like a granular appearance, plus it's bleeding. And if you look at the center photograph from Dr. Jane, you'll notice over on the left, that was done with a blade. And if you look over on the right, that was done with a laser. So we've moved from scalpel, rotary instruments, electrosurge. And what I want to speak to you for the rest of our time is this thing with using lasers and why. There are really three sort of categories of lasers here. And one is the diode, one is the erbium, and yes, it is possible to do this with the CO2, either the 10600 or the 9300. So when we look at this, we might ask ourselves, well, wait a minute. Sam, you've explained we have three possible lasers. What would you recommend? Which one is best for doing this gingival depigmentation? Well, the first thing that I would ask you is let's look at the absorption curve of these various tissue components relative to what? Laser. You and I know that there's probably 4 primary targets that lasers look for, depending on their wavelength. And so we've got melanin, which can be the brown to black. Pigment, we have blood with the hemoglobin being red. And the lasers that are primarily for this are going to be our diodes. Now, the other 2 structures that you and I take a look at, and that is going to be water, tissue structures, and bone. And Dr. Dyer very clearly demonstrated by using the erbium laser how he utilized an erbium to do both. He utilized a laser at a particular setting for the soft tissue, and then he turned it onto a different setting, possibly a different tip, when he went in to do the osseous recontouring. Now, let's think about this. In doing gingival depigmentation, we only need soft tissue. We don't need an osseous setting. So that sets us up for the fact of this. You can do gingival depigmentation with just about any dental laser out there. And when we take a look at that, it all depends upon the target. Many of you who are laser aficionados, you've seen this diagram on multiple occasions. And in fact, when the arrow goes through our target, nothing happens. When our arrow scatters into our target, nothing really happens. When our arrow laser reflects off the target, nothing really happens. You and I choose a laser based on the chromophore, based on the target. Now here, our target is primarily going to be the melanocytes and the melanin. So with that, what we want to do is actually create a level of ablation while not really getting into any thermal necrosis, hopefully, or what we call that thermal conduction. So the settings become very, very important here so that we do not insult the tissue. So let's first of all talk about diodes. Diodes range from 810 to 980. I don't want to forget about the 1064 Nd:YAGs here, because they possibly in a soft tissue setting can also do depigmentation, but there's all kinds of diodes. And I would suggest to you that all of these diodes can be effective in gingival depigmentation. Now, there's been very few really, really good studies that are comparing erbium laser and diode lasers that are out here. Here I'm showing you a couple of erbiums out there, including the water-lace erbium chromium YSGG laser. And so we're going to primarily use that particular laser as we move in the direction of technique. Now, Dr. Walid Altabab, who I've learned so much from relative to gingival depigmentation, I would suggest to you that probably one of the major resources for what we know about gingival depigmentation has really come out of the Middle East. And it's only because of the fact that hereditary pigmentation is related to certain racial arenas. So if you look at this, and this is a fairly new, this is 2021, an excellent study. Here, comparing diode to the erbium chromium YSGG. And here were the results. The treatment was significantly faster with the erbium chromium YSGG and required no or very little anesthesia. It had faster healing, and the patients experienced less postoperative discomfort after 1 week of treatment compared to the diode laser. And you can see that the statistical significance was very high. But let's be fair. What they also found was that the repigmentation intensity and extensity were higher significantly for the erbium than it was for the diode group at 1 and 2 years. So here's what you've got. You've got an erbium with faster healing, less postoperative discomfort, patients loving you. However, you have to be careful, because now I want you to think about that. If you're a laser person, guess what's happening? What is basically happening is that your diode is seeking out the melanin. It's got a much more significant absorption coefficient than you're going to find with the erbium. However, I've got some answers for you, because I exclusively use the erbium chromium YSGG, and I rarely have repigmentation except on those individuals that have a very, very dense pigment. So the conclusion is that both lasers efficiently remove gingival pigments with comparable clinical outcomes, a very positive overall experience, but the diode possibly in this study had a little bit better long-term stability with gingival color. So let's take an example of a particular case, and this is a fairly significant one. And you can see that with this, we've got our gingival pigment, and we're going to, in this particular case, we are going to use actually topical. Some of you are aware that many of us use compounding topicals. That would be our TAC 20 with tetracaine, articaine, phenylephrine. And if you go on Google, you can find that formula and then give it to your compounding pharmacist, and they will make it in liquid, they can make it in gel, and they'll make it in different flavors. So here we're starting the procedure. We've applied our topical. And now you notice that now we're removing the epithelium, the basal layer. We're getting down where the melanin is. And, you know, as Brett talked about magnification here is as critical as anywhere, because I want you to look at that area in the connective tissue. You know, what you're doing is you are ensuring that you're not seeing any pigment. And as you continue to remove layers, remember that every pass that you make with an erbium laser, you are actually just removing 25 microns. So it makes it very, very precise. And so if you look at one side where we've done this procedure and we're getting ready to do the alternate side on the asymmetrical side, you'll notice that we have effectively removed the pigment into the connective tissue area, but we've been also very judicious, and I'm going to speak about this in a moment, about how deep you can go with these types of procedures. So here we have done both the upper and the lower. Now, I also want for you to pay attention, and you may be able to see my mouse here, but notice how we maintain the margins and we maintain the papillas that we did not get. Even if there's melanin in there, we do not want to get into the free gingival margin here at this level, nor do we want to get into the papillas because of the resulting recession. And unfortunately, we could get necrosis of the papillary area. And yeah, they would not have pigmentation, but they'd have black triangles. And so here's our case approximately 45 days later, and I'm going to show you more cases as we go through this. I'm indebted to Dr. Howard Gluckman in South Africa, and here's one of his cases with pigment removal. And notice here's our pre-op, a fairly good lip line. And what we're going to do here, and this is a fairly significant, this is not a case you want to start out on. And by the way, let me give you a suggestion. The first case that you do, go ahead and tell the patient you're going to do a test area, that they're going to have to come back to complete it, but tell them that every patient is different. And if it were me, I would go back and do some depigmentation sort of back here where it's not necessarily in an aesthetic area, so that you can get used to the techniques that I'm going to show you here in a minute, instead of letting this be your full-blown case and possibly leaving melanin or possibly going too deep. I don't want to scare you about going too deep, but you do have to think about the gingival phenotype here. And this is the resulting of this particular case. I mean, it's just absolutely gorgeous and probably very, very little repigmentation down the road. And here we are before, and here we are after. Now, this might be a time that I would suggest something. There are individuals, racially, culturally, that actually believe, as they should, that this pigmentation is actually something that is positive for them. So you have to be careful of walking in and saying, hey, I can make your gums pink. No, you're much better off posting things on your website and letting them come to you rather than trying to make decisions. I've always said that aesthetics is in the eyes of the beholder. It is not about us as dental practitioners. So in this, if you look at this particular scenario, and this is Dr. Burke, I'm going to show you, and he's doing an excellent job. Notice how the angle of the laser tip is to your contact. You are not, my friends, doing straight on perpendicular. You're literally sort of removing the gingiva as if it was veneer. And you're literally just very slowly removing that epithelial layer, the basal layer, getting into the connective tissue. And you're always, by the way, in one hand, you want to have your laser. In the other hand, or with your assistant, having a 2x2, a wet 2x2, to actually blot the area so that you can visually see, because there will be a little bit of tissue tags here. So as we do this, let me get out of this, hopefully. So as we do this from this standpoint, and let me get over here for just a moment. I can get out of this thing. Here we go. So the settings that you want for gingival depigmentation with a waterless laser, these are what we consider to be fairly standard settings. Your laser power is very much of a gingivectomy at 1.5 watts. Brett talked about H mode, S mode. We like to here, because we're not going to get that much hemorrhage, we like to use the H mode. Our hertz is around 30, 35. Our water is copious, 50%. Our air is 40%. And most of us like to use the MC6 9, 6/10 with 9mm length. Now, can you use a chisel? Absolutely. But I would not start my first cases, with the chisel. So if we take a look at this, let's look at the particular technique. And with this technique, and by the way, this is on the BioLace website. This is Vimeo. And here you'll notice that we are moving back and forth very slow. You can see the pulses as we're doing this. You're just barely, if anything, touching the tissue, just lightly touching or being about a 0.5 millimeter to 1 millimeter away. And so we wanted to show you graphically what your angle is. You're using an in-firing tip here, back and forth, blotting like we discussed. Notice that we're leaving the free gingival margin. We're not getting into the papillas, as we do this. And basically, if you look at this histologically, if I go back to where the melanin is, you don't want to get into the bone. Absolutely do not get into the bone. Or what you're going to get is you're going to get primary wound healing, and you know what that's going to be. What you're going to get is osteonecrosis. So here is our case, beautifully done, not getting into the free gingival margins, not getting into the papillas, and basically getting to the area that we want. Let me see, how's I get here? And get this out of the way. Here we go. And so here are your precautions. Be careful, especially with diodes, because you don't want to heat the tissue up. And if you see brown and black, you're way too high. Try to use the gingivectomy settings, but drop it down maybe a 0.5 watt. Know your anatomy. Know your gingival thickness. And as Brett had poked holes into the gingiva to determine with the CEJ, there's nothing wrong with taking your periodontal probe and seeing just how thick this gingiva is. By the way, because you want to appreciate where your bony topography is. Friends, if you've got a lot of tori here, be careful. Avoid free gingival margins, so not to create recession or black triangles. Appreciate that you can possibly get repigmentation with very serious cases. And that happens when the melanocytes are not completely removed. And so you see down at the bottom here, this is someone's first case. And I must tell you, this is a spouse. First of all, I hope all of you know, do not work on family. And here we had tori. And here, what they did was, unfortunately, they got into the bone. And when I talked to the patient and asked him, because I was called, about that, it wasn't my case, but I was trying to help out the practitioner who had just purchased a water lace. And she was frantic and called me on the cell. And I asked the husband, I said, what's your pain level from 1 to 10? He said 15. So this rarely, I've never had this happen to me because I know topography. So let's talk about what we do after we've completed this case. Well, first of all, utilize postoperative rinses. My preference naturally is going to be Perio-Sciences AO gel, but you could use saline rinses for that matter. You could use Stella Life. I highly recommend you do not use chlorhexidine. We have seen repeatedly chlorhexidine is cytotoxic. And I just do not suggest you use chlorhexidine on these open wounds. Consider very gentle brushing with a soft brush. I like to have them take the brush and actually put it under hot water to even make it softer. And they start from the gingival margin and moving coronal. They do need to not be so, you don't want to do a subgingival debridement there, but just take and wait just a few weeks, maybe 2 to 3 weeks before, if you were to do a prophylaxis or a periodontal maintenance. And then once the tissues have healed, we like to wait at least 6 weeks if you're going to do any kind of restorative